when crisis and innovation meet during the COVID-19 pandemic to ensure the continuity of the medical curriculum, the case of online-based simulations. The COVID-19 outbreak had major implications on medical education. Since February, Canadian medical students, as most worldwide students, were compelled to pause and in some cases to suspend in-person academic activities, including lectures, clinical performance examinations, clinical training in hospital, and simulation-based activities. Learners and medical teachers were called to embrace technology, both to provide patient care and medical training. These new ways of interacting and providing care are transforming the healthcare system, including the teaching of medicine. All this could be considered a new educational paradigm in the making, as medical schools are urged to innovate and to support virtual teaching and learning. During the COVID-19 pandemic, a shift to telemedicine and online learning became imperative to overcome the spread of the virus and meet the training needs of medical students. Telesimulation is a process by which telecommunication and simulation resources are utilized to provide education, training, and/or assessment to learners at an off-site location. Telesimulation-based learning has been reported as a high-level distance experience that allows synchronous interactions between learners and instructors, making accessible training and virtual collaborative education to multi-campus, national, and even worldwide level. Although most of the experiences documented in the literature described the use of mannequin-based telesimulation, we instead relied on standardized patients who are at the high end of the fidelity continuum for training and assessing non-technical skills and competencies. In the rest of this presentation, we will briefly show you the principles and the techniques used to transform in-person simulation activities to telesimulation. In order to understand the challenges of our context, let me first explain the magnitude of our operations. At the Faculty of Medicine at the University of Montreal, we have cohorts of 300 students. We have 2 campuses and 2 simulation centers. We have 80 simulation activities that are integrated into the medical curriculum, and we have more than 150 simulation patients. At our institution, we changed the parts of our existing in-person simulation curriculum into a telesimulation experience, including activities focusing on communication, teamwork, and assessment, such as the OSCEs. These training activities were chosen out of 12 communication simulations by an academic committee chaired by the Assistant Dean for Undergraduate Studies and composed of curriculum officers for each year of the program, the directors of 2 simulation centers, as well as simulation and pedagogical experts. Although there were not explicit criteria to select the activities, the following elements played a major role in the decisions made by the committee. Prioritization of activities covering topics that were not taught or discussed in other activities being adapted to an online format. Prioritization of activities that cover topics or taught skills needed for the OSCEs. Scenarios requiring a level of fidelity attainable with telesimulation format. And finally, the number of resources needed to plan and adapt the activities to the telesimulation format. The framework that guided the telesimulation curriculum we are going to present here combined the pedagogical principles of problem-based learning, online learning, and experiential learning. Both the logistics and the instructional design of activities needed to adhere to these underlying concepts. Preparing a telesimulation curriculum for big cohorts has technical and logistical challenges. The process of planning telesimulations started a month before the activities were scheduled. The first step was to assemble a team whose mandate was to plan and run the activities. This multidisciplinary team consisted of communication and technology experts, simulation instructors, high-fidelity experts, simulation patients, managers, and experts in pedagogy. The number of team members needed for the various telesimulations varied from 9 to 14 according to the complexity and the technical needs of each activity. The team roles included 3 coordinators, several simulation instructors, Zoom operators, and pedagogical advisors. A communication channel was needed to ensure that all team members had the same information at all times. For this purpose, a Teams group was set up, which also served as an alternative communication channel during the telesimulation activities, allowing team members to update last-minute changes due to connection issues. Based on the principles of PBL, the content experts, the pedagogical advisors, and the simulation instructors worked to adapt the simulation objectives, content, and scenarios for the telesimulation format. Simulation instructors revised the scenarios and coached the professional actors to portray the right level of emotional intensity during the online activities. The technical and the pedagogical team designed a Zoom environment and built a flowchart to meet the needs of each scenario. This flowchart specified the transitions needed to ensure small group interactions. These diagrams identify the Zoom tools necessary for the progression of the activity and the orientation of the students through a path, taking them from the scenario to the debriefing. The flowchart ensured the standardization of the procedures, allowing the team members to understand and configure the virtual environment. The quality of telesimulation activities relies enormously on team training and proper anticipation of technical difficulties. A test run was scheduled for each telesimulation 1 or 2 weeks before the activity. It included all the participants except the learners. Cross-training was provided for all members of the team in order to implement contingency plans due to technical or interruptions in the internet connection. Similarly, backup instructors and backup actors were also included in all the activities. Students were scheduled to connect in groups of 20 students that were then divided in 4 groups of 5 to allow an active participation. Although one student was assigned in advance to take the lead in communicating with the virtual patient, the rest of the students were also assigned in advance an observer role and take notes about different aspects of communication and the patient-doctor relationship, which were later debriefed. A learning contract addressing the needs to engage and actively participate in the online format was distributed and signed by the students, actors, and instructors participating in the activity. The Qualtrics platform was used to distribute it. More precisely, the contract addressed the following elements. The format. In this section, participants were informed about the format differences between the online and the in-person simulations, including the fact that they were going to have pre-assigned roles. They were told about the needs to have a professional behavior at all times, to suspend disbelief and engage in their role as physicians, which required connecting on time and wearing a white coat, as they usually do at the hospital. They were also asked to engage in a respectful relationship with the simulation patients, as they would in a telemedicine consult. Confidentiality of scenarios. Participants were informed about their moral obligation not to talk about the scenarios and other participants' performance. Zoom recording functions were disabled for the participants who were asked not to use any other device to record or capture any part of the activity. They were informed about the fact that if they try to use the recording functions, the pedagogical team will be alerted and they risked being expelled from the activity. Security and good Zoom practices. Participants were asked to use a stable connection and to connect via the Moodle platform at the university. They were also asked to upload the last version to guarantee that all functionalities will work when needed. Authorization to record and review video recordings for technical, educational, and research purposes. Participants were asked to consent or not to the use of their data for further technical and/or research purposes. To ensure standardization in the activities and in the online procedures, specific Zoom tutorials were created. In addition, students were provided with video capsules presenting the theoretical concepts applied in the simulations. These videos summarized the theory and modeled expert clinicians' problem-solving and decision-making strategies. They were uploaded to a private YouTube account, and analytics were used to monitor how students used the videos to prepare themselves. Although the inclusion of preparatory material was commonly used for our in-person traditional simulations, the flipping classroom, and the analytics were new additions to our pedagogical formula. Finally, and to close this presentation, here there are some recommendations. From a technical point of view, that means Zoom operators, it is important that they are familiarized with simulation-based training. Try to keep the plan as simple as possible. Adapt the changes of the structure and adjust the timing in a faster manner. From a simulation instructor point of view, it is important to have good knowledge of the activity, at the content, and at the logistic level. Standardize the briefing and the debriefing points among instructors. Keep your role as facilitator and avoid to solve technical problems. Promote learners' participation. Attribute roles ahead of time and call students by their names. Be mindful of time and follow the protocol described in the flowchart. From a pedagogical point of view, it is important to revise and adapt the learning objectives to the virtual format. Do not transfer the same objectives from in-person simulations to telesimulations. Keep all learners active at all times. And from a standardized patient point of view, it is important to choose actors with expertise in simulation and who feel comfortable using technology. Standardize the performance of the simulation patients. That means define the corporal and the intensity of the emotional reactions that need to be privileged and emphasized or minimized in the virtual environment. Thank you very much for your attention.